A very amicable morning to all. It won't be less agreeable after the rain showers yesterday. I, Dr. Parul Sauji,
Dr. Shilpa Joshi, welcome you all on behalf of Omega Hospital to this CME Window of Opportunity organized by Omega Hospital, Om Charitable Trust in collaboration with Nagpur Obsgynae Society.
to make this session more interesting, we all have voting pads on the one seat. Two people will be sharing one voting pad, and before every speaker, we will be having a voting session for the questions.
Starting with the first session, I invite Dr. Pratima Radhakrishnan Madam, who is Director of Bangalore Fetal Medicine Specialist for the first lecture. Welcome, ma'am.
Good morning, everybody, and thank you very much for coming today to listen to and hopefully take back some valid points from what is something which is extremely, extremely close to the hearts of most obstetricians, and that is the fetus. And I really like the word window of opportunity, which has been coined by Dr. Chaitanya, because it is truly the most important window of opportunity, because all this time medical science has been concentrating on treatment aspects of obstetrics and fetal medicine. But here is a time where you can screen for many fetal problems, maternal complications, and therefore it is the most important window that needs to be opened, and I hope to give you a good peek inside the fetal life before 14 weeks with my entire team today. So let's start with first trimester screening, and I've specifically added in India because it's not very uncommon. Wherever I go, you do this, you do this abroad, you do this here, you do this there, but can you do it in India? And this is my this particular talk, this is the first time I'm delivering it here, and I'm very pleased to do this in Nagpur. But before that, let's quickly recap. After all, what is the aim of antenatal care? Antenatal care is basically to screen for congenital anomalies, detect structural anomalies, placental insufficiency problems, which is primarily preeclampsia, fetal growth restriction, and preterm delivery and prematurity, and pretty much everything that you do in antenatal care actually is just these things, right? Now, there's very few things that you would do anything other than that. Everything aims to these three main headings, and in this way you want to reduce your perinatal mortality, morbidity as well. So first let's understand the principles of screening. This is very important because then only you will be able to understand how we go along with particularly various terminologies which can be sometimes quite confusing to the doctorly minds. The aim of the first trimester scan is to optimize antenatal care, to get accurate information, and of course to facilitate delivery in the right place at the right time. And the aim of every obstetrician is of course to give good outcomes to the mother and to the baby. Now in India, about 500,000 babies are born with congenital anomalies, and this is huge. Now most of them are related to either genetic or chromosomal abnormalities, and Down syndrome is indeed still the most common chromosomal abnormality, and we have about 21 to 20, over 20,000 babies born with Down syndrome every year. Now, you may not be able to see that because they are not all of them are detected at birth. They are detected over a period of time as well. Followed by thalassemia major, which is a very, very common, particularly in certain parts. And I really don't go much by consanguinity anymore, because there are certain genes or faulty genes which are more common in certain communities, and this is because we have been having intra-community marriages for a very long time. So all your bad genes have remained in the community itself. So over a period of time, your consanguineous marriages will be almost as, or your intra-community marriages is going to catch up with your consanguinity as well. And but before we go into screening, we need to understand what is diagnosis. Diagnosis is a confirmation. Confirmation is like means 100% or almost 100%, and there are mainly two tests that we perform for a diagnosis of a chromosomal abnormality, and that is either a chorionic villus sampling, where we check, where we check for the, can you see that? Sorry. The chromosomal abnormality, particularly chorionic villus sampling, which is taking sample of, get my laser pointer here. Okay, chorionic villus sampling, which takes sample from the placenta, and amniocentesis, which takes sample from the amniotic fluid. And of course, one must be very wary when you're doing these procedures about the safety, the diagnostic accuracy, the timing and technique, of course. Now, traditionally, CVS is performed before 14 weeks or maybe 16 weeks, and typically at that point of time, the risk of miscarriage is relatively higher, even spontaneous miscarriages, right? Now, what people believe that the risk of miscarriage with a CVS is higher, one need to dissociate the risk of miscarriage or the possibility of miscarriage because of a procedure versus background risk. Now, background risk will always be there, irrespective whether you do a procedure or you don't do a procedure. By doing a procedure, you're increasing the background risk by a small percentage, and that is called the procedure-related risk. And randomized control studies have shown that there is no difference in the risk of total pregnancy loss, irrespective whether you do a CVS or whether you do amniocentesis, and this is primarily because the timing at which you do the CVS, the risk of, background risk of pregnancy loss is relatively higher. Now, when I say this, of course, it depends who does it, right? Now, anybody and everybody are not trained to do invasive procedures, and therefore, it must be done by people who are trained, and then you can achieve these kind of figures. Now, very important counseling points as obstetricians, as radiologists, as sonologists, or whoever cares for the fetus, basically, they need to know that amniocentesis must be performed only after 16 weeks, and this is because there are structural abnormalities associated by doing an early amniocentesis, 1, and 2, the possibility of pulmonary hyperplasia, congenital talipes, and miscarriage, all are increased by doing amniocentesis before 16 weeks. So if you have to choose a diagnostic test before 16 weeks, it would be a CVS, and after 16 weeks, once the chorioamniotic membrane has fused with, once the chorioamniotic membrane has fused, then you would do the amniocentesis. And as I already said, the risk of miscarriage is pretty much the same. So that brings me to screening. Now, historically, we have seen that women over the age of 35 years, and if anybody is still practicing, then they're going back almost 50 years to 1970s, which is when women over the age of 35 had screening. Then we had the double marker and triple marker, and again, I'd like to emphasize people, you need to move on from triple marker test, because triple marker test is obsolete. It's out of the window. We're not going to even talk about triple marker test at any point of time, right? So that was in 1980s, because we have got better tests. We have got the nuchal translucency, we have got the combined first trimester screening, we've got the second trimester quadruple test, and Surus study showed that if you combine the first trimester screening, which is the NT with the biochemistry, and the second trimester screening with the biochemistry, again the quadruple marker test with the genetic sonogram, you can achieve detection rates of nearly 85 to 90%, which is almost the same as your first trimester screening. Now, if you use additional markers on the scan, like your ductus venosus or the tricuspid wave Doppler, then it gets even better. And finally, that's what happened in 2014 Any guesses? Is the cell-free DNA that came in, and cell-free DNA is a screening test. You remember, I did not mention that as a diagnostic test because cell-free DNA is a maternal blood test. It has got an extremely high accuracy of over 99%, but particularly for Down syndrome, but it is not a diagnostic test because you're not actually testing the fetal cells. So it is not fetal DNA, it's cell-free pregnancy-related DNA. Okay? Now, screening primarily should be aiming at healthy women. Healthy people are screened. It's not the diseased people. If you've detected a disease, you've already made a diagnosis. So you are looking at apparently healthy people to see which are the women who are more likely to have a fetus with chromosomal abnormality or whatever condition that you're screening for, right? So that is called the detection rate. So here is a population that you're applying a sieve, you're applying a filter, right? And when you put the filter on, the few of them will go down, some of them will stay on the top. Now, the ones which stay on the top are the ones which will require further assessment, and this is your screen positive group, okay? And what has gone down are screen negative group, right? Now, in the screen positive group, you need to detect as many babies with Down syndrome. So what is above the sieve should have more babies with the chromosomal abnormalities or Down syndrome. Let's take Down syndrome because that's the commonest thing, than what is below the sieve. And that is called the detection rate. So your sieve, which is your test, must be strong enough to be able to pick up as many babies with chromosomal abnormalities and allow almost all the normal babies to go down. And this is your test, okay? So when you do the, and then that is your detection rate, that how many you are able to detect by applying the sieve which are on the top of the sieve. Here it is 3. Whereas the one which has escaped there is your false negative. False negative means it has got Down syndrome, it has got the disease, but it has escaped the sieve. But in addition, you've got a few other green ones there, which are all normal. Because they're normal, they have been picked up on the sieve, and these are your false positive. In prenatal screening, pretty much the false positive is the same as your invasive testing rate, because the ones which are going to be above the sieve is what you're going to do your invasive tests on. So that is your invasive testing rate, which you want to keep as low as possible to be able to pick up as many babies with chromosomal abnormalities or Down syndrome as possible, and of course miss as few as possible. Now, in 1800s, Langdon Down described Down syndrome. In the skin is deficient, there is increased elasticity, there is a flat face, and of course in 1990s, Kypros Nicolaides was the one who described this on the ultrasound scan, that there are about 75 to 80% of babies with Down syndrome would have increased nuchal translucency, and about nearly 60% of babies with Down syndrome would have a hypoplastic or an absent or a small nasal bone. And subsequently, we have got various guidelines, and the two most followed guidelines are the Fetal Medicine Foundation guidelines and the International Society of OBG guidelines, and all these are available freely online. So you must go there and check out these things. Sooner the better. So what is the purpose of your first trimester scan? You confirm the gestational age, and this is the best time to confirm the gestational age because you can measure the crown rump length properly, because you can see the ends of the baby much better. Of course, you confirm that it's a viable pregnancy. If it's more than one baby, you confirm the chorionicity, amnionicity. You screen for chromosomal abnormalities, multiple abnormalities, fetal abnormalities, and preeclampsia FGR. And we are going to pretty much cover most of it except for the multiple pregnancy part of it. Now, coming to screening for chromosomal abnormalities, we know when you screen for chromosomal abnormalities, one of the most important measurement to take is the crown rump length, and then you need to zoom the image and then measure the NT. I'm not going to go much on the technique here because Sonal after me is going to cover that for you. Now, when this is the one image that you need to remember. If you're an obstetrician, this is the image, or this is the only image that you need to rely upon, that to say that your NT has been measured correctly by your sonologist. If you're a radiologist or a sonologist, or if you're doing NT scans, then this is the only image that you have to procure, because any other changes in the angle of measuring the NT will change the numbers drastically. So memorize this picture, and one of the important clues that I tell people when they're doing the NT scan is just draw a line there. And if the head occupies, because magnification is something that most people suffer from, I would say, because they don't magnify the image enough. And remember, we are measuring millimeters here. We are not measuring centimeters. We're measuring millimeters. So a millimeter from 2.3 to 2.6 will make all the difference. And it is only 0.3 millimeter difference, right? And just a slight movement of your hand on the tracker ball can make that difference, right? So put a line at the head, and you know if 75% is on the left side, that is the 75% magnification, right? So most of the head is to the left of the screen, and of course you have to make sure that you have brought the tip of the vertex to the tip of the screen there. Now the other thing, very importantly, one must remember that as the NT increases, as the CRL increases, the range of NT increases. And when we combine that, maternal age with NT must be combined to give the risk for chromosomal abnormalities. So maternal age is always the a priori risk, that is your starting point risk. Now this is a study, I don't know how many of you have gone through this. This is a recent publication that we have had in the beginning of 2019 with the Delhi and the Bangalore teams. And now I'm going to start showing you data which has been almost all of them done in India, right? To prove to you that this is a thing that we can very much adopt and we can do very well if we are really motivated to do it right and do it with perseverance and with diligence. Now, this is about 14,000 pregnancies where we measured the crown rump length and nuchal translucency. Of course, all of them were Fetal Medicine Foundation accredited operators. And now the biggest problem was we realized that not everybody has the software, and there's a problem with resource, and to be able to enable more people to use the